Hello, my name is Dr. Mark Rosenthal. I'm a consultant respiratory paediatrician at the Royal Brompton Hospital, and this is a talk I have given to general practitioners about the coughing child. Here is a photograph of me and my website. So to get onto the talk proper. A cough can be looked at just in the same way as a medical student was taught the features of a pain: site, sort, severity, onset, duration, periodicity, aggravating and relieving factors, and time off work or school. It is, of course, all in the history. The age of the child when presenting, the age of onset, which is crucial, whether it is acute or chronic, and the definitions of chronic is more than 3 weeks or more than 8 weeks, episodic or continuous, dry or wet or with some other quality, whether there are associated symptoms, for example, wheezing, and all of these I will come back to later. Of course, I'm telling you what you all know already, but just to remind everybody that not everything that coughs is asthma, and certainly not everything that wheezes is asthma, but I will also come back to that as well. Everything in life is pattern recognition, and that is what happens in pediatrics just as in any other field of human activity. So, if you see something that has fur, floppy ears, wags its tail, and barks, then it really is probably a dog and not a zebra. And that should always be remembered, because features that don't fit the pattern shouldn't be pushed in to make it fit, and that is what often happens. So here are some patterns of a cough, with duration along the x-axis and intensity along the y-axis. So here is an example of an acute cough with a delayed recovery that happens very commonly with viral related type symptoms. Here is recurrent acute cough with an episode here to no symptoms at all and completely well there, and back to another acute episode later on. And of course, more worrying is the persistent non-remitting cough, this third example here. Age of onset is extremely important. If it is at birth, then one always has to think of congenital abnormalities, structural abnormalities, etc. If it occurs at 2 weeks of age, then it tends to be gastroesophageal reflux, possible bronchiolitis, laryngomalacia, cystic fibrosis, because even though there is now screening, the odd one slips through every year, and a foreign body from a helpful sibling. And after 4 months, of course, infectious viral illnesses becomes extremely dominant, but the other things can also occur at that time as well. One must always challenge the answer from birth if the question was, when did all this start? Because if you actually challenge that, then parents will often say, oh, well, it wasn't actually from birth, it was from 2 months or 4 months or 6 months. That also depends on the age of the child. If it's a 6-year-old, then they'll have forgotten when it all started. So a word about, well, I'm going to get you to think about it. A well child developing normally starts a wet cough at around a month of age. It's intermittent, occurs randomly day or night, or day and night, and the child isn't particularly unwell, but doesn't respond to any of the usual things that are offered for chest infections. What do you think the diagnosis may be? Sadly, of course, I can't hear your answers, so I will go on and give it to you. Always consider aspiration from above. 20 years ago, I would never have thought it possible in a neurologically normal child that you could aspirate liquids. However, it is far more common than I, and indeed anybody else, realized. Of course, it's very common in people with neurological abnormalities such as Down syndrome, but it is very common in the neurologically normal. No, not very common, well recognized. It is almost always a maturational swallowing problem. It is more likely to have that diagnosis if there are additional symptoms on history taking of eye watering with feeds or a wet voice, but quite often you will not get coughing or choking with a feed, so-called silent aspiration. The speech and language people are, of course, very helpful. Some people do MRI scans of the head and cervical spine and or muscle testing to look for bulbar palsy, and they do occasionally find it. No action is required. Feed thickeners is the treatment, and 95% have grown out of it by the age of 4.5 years, although for situations like Down syndrome, it can take a lot longer. The age of the child is relevant, as well as the age, because it gives you a better idea of severity. Has it gone on for years and the child is clearly very well, or has it gone on for a very short time and the child is not well? It gives you a much better image of the pattern. And of course, acute or chronic. If, as was told to me once in clinic, it starts at 6:15 p.m. on the 4th of January, the cough, a foreign body should always be considered, and failure to consider it or gloss over it always seems to result in trouble. And I, in one of my pastimes, do medico-legal cases, and the number one gets with this issue is too many. And I wish to remind you that a normal chest x-ray does not exclude a foreign body. So any history of an object in the mouth, choking, etc., has to be assumed to be correct. And the only way of excluding a foreign body is with a bronchoscopy, and that, at least in this area of London, is done by the ENT surgeons. And the other question about acute versus chronic is the interaction between coughing, acute coughing, and the age of the child. So human rhinovirus, which is an incredibly common virus of viral illnesses, leads to coughing when aged 1, and that has a very low risk of predicting asthma at the age of 7 years. However, a human rhinovirus infection at the age of 3 has a much higher risk of leading or being associated with, though causation is less clear, an asthmatic at the age of 7. Whooping cough, even if vaccinated as a baby, is still not rare in the older child because the vaccine tends to wear off after a few years, and where the herd immunity was to protect the young baby in the individual, it can wear off and lead to symptoms later. And I see a steady trickle of people presenting with classical features of a whooping cough, i.e. bouts of coughing, seemingly occurring at random, not related particularly to exercise or emotion, gets worse over a 3 to 4 week period and lasts again for about 4 weeks and fades away. And more than a third of children from a GP study around Oxford had serological evidence of whooping cough, especially of whooping, vomiting, or producing sputum. And the duration of the cough, which could be very protracted, though lasted less than 200 days, was longer for the serology positive chronic coughers than for the serology negative chronic coughers. The other issue in the history is whether it's episodic, and here are two classical patterns. One, the pattern at the top is a child with background symptoms with acute exacerbations on top, and the one at the bottom is a child with no background symptoms, but that is interrupted by acute episodes of coughing. And these are not distinct patterns, which was once thought of at least about 8 to 10 years ago, and in fact, children can change from one pattern to another and indeed back again. The question about whether a cough is dry or wet is relevant. If it's wet, it's upper or lower airway secretions, and considering gastroesophageal reflux, but that can also be dry, and aspiration, but also consider a postnasal drip and ask the question, does the child snore? I am always struck by the fact that parents will never volunteer regular childhood snoring and mouth breathing unless actually asked for. CF, of course, does occur despite screening. If it's dry, it's more likely in the asthma, possibly gastroesophageal reflux. Gastroesophageal reflux, much more common. Still, I note a reluctance to give treatment. You don't obviously have to vomit. Getting a history can be very difficult, but you can get all sorts of issues of coughing at night, crying at night, fussiness, etc. And a trial of treatment is the best way of making the diagnosis. And I would recommend omeprazole or any of the other azoles. But remember that omeprazole has to be given twice a day because it only lasts 17 hours. So if it's given in the morning, and of course the symptoms are at night, it will have run out. And there's been some quite good studies on the role of gastroesophageal reflux in particularly young children under the age of 2 with an unexplained cough. And they reckon that about 50% of children with a chronic unexplained cough had reflux-related cough episodes, mainly in the day and without gastrointestinal symptoms. Again, associated symptoms are very important, and wheezing is, of course, extremely common. However, not everyone that wheezes has wheezing, and not everyone with wheezing has asthma, and certainly not everyone with asthma has wheezing. The issue is that there are only 3 respiratory noises. Stridor, which is of course an inspiratory noise, which increases from a low to a high pitch. Wheezing, which is expiratory and goes from a high pitch to a low pitch. And stertor, which is this gargling sound that occurs both in inspiration and expiration and sounds like someone blowing through milk with a straw like this. And this should be regarded as a normal variation in children between the ages of 6 months and 2 years. And why they do it, I don't know, but they certainly do it. And it is not wheezing, which often is the confusion in parents' minds. And of course, parents only know 2 words in this respect. One is croup and the other is wheezing. And of course, stertor is not wheezing, is not asthma, and doesn't need any treatment. So never accept the parent's word that their child is wheezing unless you've checked it out. And I use the killer question, which is, tell me what you mean by wheezing. And then we end up with all sorts of confusion, and stertor occurs a lot of the time. And even the parent's ability to match the wheezing video to the doctor-observed wheezing child is only about 50%, so no better than tossing a coin. So it's well worth exploring the issue of wheezing if it hasn't been directly observed. Okay, so here are some cases with a common theme. This is a 10-year-old boy attending a choir school who 3 months previously, following a mild viral illness with a mild cough, progressed to an increasingly severe honking cough that was heard 3 times during the consultation, and this prevented him singing. He may have had trivial asthma some years previously. What is the one question you ask that gives the diagnosis? It's November, and a boy presents with increasingly difficult to control asthma for the past 2 months. He was known to you for 3 years with mild asthma needing 12 months of inhaled steroids at low dose, no casualty presentations in the past, and for the previous 18 months had used a bronchodilator about 4 times a year. So my question to you is how old is he and what happened 2 months ago? The third case is a talented female tennis player who started at a full-time tennis academy in Hertfordshire. She gradually notices that during the group warm-up exercises that involve running as fast as possible around the tennis court, that after 4 goes she develops an increasing sense of constriction in her upper chest, finding it impossible to breathe and fears she will collapse and die. She recovers after about 10 minutes. Over a 6-week period, these symptoms have started coming on earlier and earlier during the warm-up and has now started occurring during practice matches. What do you expect to find on examination? So, the answer to this one is, do the symptoms occur when he is asleep? Not when he's in bed, not at night, but when he is asleep. And the answer to this question is, how old is he? And what happened 2 months ago is that he's about 11 or possibly 13, depending on whether he's going to what type of school, and he went to a new secondary school 2 months previously. And the answer to this is that you will find absolutely nothing on examination and the person will be completely well. And these are all features of what might be called a habit tic or functional symptom disorders, none of which ever occur when the child is asleep. With regard to the tennis player, this has now graduated to a more formal title of EILO, which stands for EILO, or exercise-induced laryngeal obstruction, and often occurs when the person concerned is finding it difficult to cope in this ultra-high pressure environment, and that's when the symptoms start to occur. All of these have a subconscious psychological basis, and therefore it is always worth considering these issues when a patient comes to see you. So, to summarize, as always, take a history and then take an even better history. Does the child snore? Do they aspirate? Not everything, of course, is asthma. Beware of foreign bodies, because it will catch one out. And trials of treatment for asthma or anti-reflux or Montelukast for viral symptoms should be for only a maximum of a month, and then it should be reassessed. And of course, failure for these treatment courses is a reason for considering alternative diagnoses. Once again, I'm very sorry I wasn't able to be here. If you have been, thank you for listening and have a very good morning, and I hope to see you around at some time. Bye-bye.